Now, moving on to the next study that we have here by Dr. Jennifer Crenchey and Moses Alfaro in their article titled, quote, Lichen Planopilaris Mimicking Androgenetic Alopecia, the Importance of Using a Dermatoscope, unquote. And this paper shows exactly what the title implies. Lichen planopilaris can mimic androgenetic alopecia, so there has to be a bit more of an elaborated look, but in this particular paper they were talking about using a dermatoscope to magnify the scalp and hair follicles so they can look for signs like parafollicular inflammation, which could be indicative of lichen planopilaris. But in any case, it's essentially showing that, yes, you have to actually look and have a bit more of an investigation when it comes to looking at somebody's scalp, right? And the same findings are noted by Dr. Ralph Trueb and Martin Zinkernagel in the paper titled, quote, Fibrosing Alopecia in a Pattern Distribution, Patterned Lichen Planopilaris or Androgenetic Alopecia with a Lichenoid Tissue Reaction Pattern, unquote. And pretty much, like I said, it's the same point. Lichen planopilaris and its variants being frontal fibrosing alopecia can potentially manifest in a Norwood-like androgenetic alopecia pattern. So if a dermatologist or a hair transplant doctor was just looking at the scalp and didn't want to do any further investigations and gave that person finasteride or dutasteride, they would continue losing hair. If they gave them a hair transplant, they would continue losing hair, because these people are dealing with issues outside of DHT. It's an autoimmune condition. And just to highlight how extreme this bias in the literature is, which would have been a better thing to point out here, Dr. Paresis and hair chemist, okay? This would have been more productive if you guys actually looked into something like this and talked about this rather than fear-mongering about dutasteride's efficacy and safety. Let's just look at a study titled, quote, Lichen planopilaris in Women, a retrospective review of 232 women seen at Mayo Clinic from 1992 to 2016, unquote, by Sidney C. Larkin et al. And this study notes that lichen planopilaris predominantly affects women with a mean age diagnosis of 59.8 years. Now, the inclusion of a large number of women who are biopsied underscores the diagnostic approach typically taken for female patients experiencing hair loss. The authors, however, specifically state that, quote, men were excluded from this study to more accurately determine the association of hormonal factors in lichen planopilaris pathogenesis, unquote. Whoa, this is odd. So this exclusion of men prevents us from knowing the possibilities of any potential histopathological differences that lichen planopilaris may present in males or even hormonal factors that could possibly exist beyond DHT. Now, I'm particularly concerned about the study's population selection, which mostly skews towards postmenopausal or menopausal women. The study finds that these women who presented with lichen planopilaris also had other comorbid conditions like diabetes, skin cancer, nutritional deficiencies, and much more. So not having a more rigorous investigation leaves out a lot of people, including, as I've previously stated, women who may not be menopausal or postmenopausal, but have a slow progressing scarring alopecia condition like lichen planopilaris. I just think it's crazy because it's implied that they did have the data for men. It is a retrospective review, right? But they just kind of like left it out because of a sort of preconceived notion that this condition only affects women, which, you know, again, it's just a bad reasoning and bias that exists in the literature. But it gets even more serious than that, because as I mentioned, this study found that these women are comorbid with other conditions, right? Well, let's look at it this way. Autoimmune conditions, even something like an autoimmune hair loss, has studies that show if you have one autoimmune condition, you may already have another one, or at some point you will develop another condition, such that autoimmune conditions are co-occurring. We can refer to this study titled, quote, Incidence, Prevalence, and Co-occurrence of Autoimmune Disorders over Time, and by Age, Sex, and Socioeconomic Status, a population-based cohort of 22 million individuals in the UK, unquote, by epidemiologist Dr. Natalie Conrad et al., published in 2023, and it highlights that autoimmune diseases, again, like I said before, are co-occurring. So, I guess, sorry for the spoiler. And just to highlight how weird the lichen planopilaris studies are and how the data just seems so skewed and kind of warped by this selection bias, we're going to look at a study published in September of 2022 titled, quote, Prevalence of Lichen Planopilaris in the United States, unquote, which was published in the Journal of American Dermatology International by Dr. Tejas P. Joshi et al. This cross-sectional study aimed to estimate the prevalence of Lichen Planopilaris using data from the All of Us research program. Out of 654,000 participants, only 142 had Lichen Planopilaris, representing a prevalence of, get ready for this, 0.043%. The study found that 91.6% of Lichen Planopilaris patients were female, with the highest prevalence among white participants, and an average age of diagnosis being 62.4 years. So I have a question for the people that did this research, and just anyone in this field. How many of these Lichen Planopilaris cases were biopsy confirmed? How many of the androgenetic alopecia cases were confirmed with biopsy? If diagnoses were based on visual assessment without biopsy confirmation, the prevalence in the data may be biased, particularly regarding gender. The study seems to support a preconceived notion that Lichen Planopilaris mainly affects postmenopausal women. And again, if you're only checking postmenopausal women when they present with these issues, then you're only going to have them recorded in the data, right? Because the biopsy data that would confirm Lichen Planopilaris, you're only using that for them. So it's showing the selection bias here in real time. And it may even be the case that some of the androgenetic alopecia cases could also have overlapping histopathological features that are similar to Lichen Planopilaris, or even other autoimmune conditions. If biopsies aren't being done on everyone in this dataset, it could very well be the case that Lichen Planopilaris is underreported. And this isn't even me just saying this. One of the world's leading dermatologists, Dr. Jeffrey Donovan, even holds this sentiment. On the matter, he states this regarding Lichen Planopilaris. He says, quote, one needs to take into account the patient's entire story. If a physician just biopsies every patient that comes into the office, I can guarantee one will make a whole lot more diagnoses of Lichen Planopilaris than truly are present. I'm a big believer in this, even though Lichen Planopilaris is underdiagnosed in the world. Unquote. So with all of this in mind, there's a clear selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Additionally, biopsies might be underutilized in women with slow-progressing hair loss conditions like a gradual progression of Lichen Planopilaris that destroys hair follicles over years. These women might be excluded from biopsy data for a considerable amount of time.